Peter, you are on the stage. Peter is a pediatric intensivist, medical director of the Pediatric Intensive Care Unit of Leiden in the Netherlands. Peter, please, thanks a lot.
Thank you, Jonathan, and thank you, Matteo, for inviting me and for setting off this session on pediatric ECPR. You've asked me to talk about the physiologic approach to ECPR. So I'm going to focus on that and start off. The slides are working a bit against us at the moment, so please bear with us as I'm focusing on several screens here. What I wanted to talk to you about today is why do children end up in cardiac arrest, and how can ECMO possibly play a role in that scenario? As you all know, children compared to adults have a very long, usually a long pre-arrest phase. There are several ways that children can end up in cardiac arrest, and mainly it's respiratory in origin due to prolonged hypoxia, which leads to cardiac arrest. So an acute setting might be a foreign body obstruction, but often it's a prolonged illness with respiratory distress, asthma and pneumonitis that leads to prolonged hypoxia. So the children have been sick for a while before they end up in cardiac arrest, which is different in adults who may have arrhythmia or myocardial infarction and have an acute phase incident of cardiac arrest. Of course, there are children as well who have circulatory failure. And most of them are children with hypovolemia from simple gastroenteritis who've been ill for a while as well before they end up in circulatory failure and end up in cardiac arrest. There's only a small portion of children with arrhythmia or heart failure or post-heart surgery that have an acute and short pre-arrest phase. And those are mainly the children that we see in hospital, and that might be important for the outcomes, which we will get to later. So out-of-hospital cardiac arrest is something that will be talked about later on. There will be an interesting discussion between two of my colleagues talking about out-of-hospital cardiac arrest, so I don't want to focus on that too much, other than saying that the conventional CPR in children has poor outcomes because of this prolonged pre-arrest phase. And you can see that some children do have return of spontaneous circulation in about a third of the patients, but then only about 10% actually survive to hospital discharge. There's quite some attrition between ROSC and actually leaving the hospital. So that's an important issue, and that's a part where I think ECMO might play a role. In-hospital cardiac arrest is different in that it could possibly mean that children have a shorter pre-arrest phase and that children are in hospital where a trained team is available to help. If we look at how often conventional CPR occurs in hospital, we know this a little bit about children in PICU. So we know that in about 5% of children in PICU and cardiac arrest can occur, and that about 50%, broadly speaking, will have return of spontaneous circulation. And of those 50%, depending on which study you look at and depending on what the underlying problem is, you have about 10 to 50% survival to hospital discharge. So there's still some significant attrition, still a significant amount of children that die after having regained spontaneous circulation. And we know that if you have CPR that lasts for more than 20 minutes, and certainly more than 30 minutes, we approach 100% mortality in conventional CPR. So this is something that we, of course, want to improve. And the question is how we can improve this. Well, very recently, the new American Heart Association guidelines have been published about pediatric resuscitation, and it's very important that we have for in-hospital cardiac arrest and for out-hospital cardiac arrest, make sure that we try and prevent cardiac arrest, of course. So we identify patients at risk in the hospital. We have early warning systems in place, and in the out of hospital environment, we try to place safety initiatives, prevent SIDS, train people. So these are very important aspects in the chain of survival from pediatric cardiac arrest. We want to make sure that people are quickly and actively activated, so an emergency response is activated quickly, and then we want to deliver high-quality CPR. Very briefly, what is high-quality CPR? You have to have adequate depth, optimal rate. You have to minimize interruption of chest compression. You want to have a full chest recoil. You want to avoid excessive ventilation. You want to give adrenaline as soon as possible in a non-shockable state, and you want to shock as soon as possible in a shockable state. And we want to train this. We want to make sure that people know this and use properly in hospital, but also out of hospital. This could make a significant impact. Advanced resuscitation in the hospital is not just adrenaline as soon as possible, and we can talk a lot about how much and how often, which I don't want to go into at the moment, but you have to make sure that you have a protocol in place, that you know when to give which antiarrhythmics, other specific drugs like calcium, sodium bicarb. These are all very well described in the current guidelines. And you need to train your team on how to use this, and especially also focusing on an airway, since a lot of these children have airway problems. Now, and then at the end of all that, you want to get the basics right. Then we can start thinking possibly about ECMO in a child who is resuscitated. We'll get back to that later. After the child has ROSC, you then want to focus on your post-cardiac arrest care. Not something I will go into now, but something Tim will talk about when we think about the neurological outcomes of children as well. And then we hope for recovery. So what's the role of ECMO in CPR? This is a situation in our hospital a few years ago, a child that was with an SVT that we had to resuscitate onto ECMO. So this is an arrest that happened in the hospital. In ICU with a team standing by, and we were very quick and able to start ECMO. But the question is there actually a role for ECMO in CPR? And if so, why do we think it works, or why do I think it works? Well, I think, like I've mentioned, it is possible in about 50% to regain spontaneous circulation, but we lose quite a few patients in the ROSC phase. And I think that's because they've had a lot of medication, they have a poor perfusion, their cardiac function is still diminished. We give them inotropes, they're cold, they're peripherally constricted, they develop multi-organ failure syndrome. So there's a lot of things that still happens to these children. They are acidotic. We have trouble ventilating them often. So there's quite a few issues still going on. So the cardiac arrest and the CPR set in motion a process of ongoing deterioration. And I think that ECMO can play a role by breaking that cycle of continuous deterioration in certain children. And I think we can do this by actually adequately resting the heart. So if we properly rest the heart with ECMO, it actually has a chance to recover from its initial insult, and possibly also from the reason it actually came into cardiac arrest. With ECMO, we can provide adequate systemic perfusion. We're talking about VA ECMO here, and we can perfuse the system very well. So we have very good systemic oxygenation, microcirculation. We anticoagulate the patient because we want to anticoagulate the ECMO circuit. But I think it also could have some beneficial effects on the microperfusion if diffuse intravascular coagulation becomes an issue. Maybe anticoagulants can help improve the microperfusion. We can limit high ventilator pressures because the children can be left alone on rest settings and to avoid collapse of the lung, but we don't need to necessarily ventilate them very hard, which can help in the coming days after the insult. And there's a lot that can be said about temperature management, but we all know that a high temperature is bad, and with ECMO we can keep at least normothermia. And if you want to do hypothermia, that's okay too, but I think the most important aspect is that we can prevent hyperthermia with our ECMO machine. So there's quite a few things that physiologically are happening after the initial insult that we can sort of manage with our ECMO circuit. And we know that these actually can give quite good results. Almost 10 years ago, this review was published by Joffe and colleagues showing 14 ECPR studies in about 800 children, where they showed that after an average duration of CPR for children with cardiac disease, average duration of CPR of 45 to 60 minutes, they had a cumulative survival of about 50%. This has been a few years ago, and since then a few other papers have been published that support this. Let me see where we are. Yeah, that support this, and that ECPR can be beneficial for children with cardiac disease who have an in-hospital cardiac arrest situation. Predictors of survival are quick start of CPR, good quality CPR, in-hospital cardiac arrest, that you have a cardiac catheterization during ECMO. I will briefly mention this in a minute. And what increases your mortality is if you have an out-of-hospital cardiac arrest, if you have non-cardiac disease, if you have renal failure, if you are on ECMO longer. So these are sort of the main things that we also see in cardiac ECMO, VA ECMO. The longer you are on ECMO, the higher the chances are that you might not survive. But what about duration of CPR? In these studies that they looked at, they had 11 studies and that commented on the duration of CPR before ECPR. And only 2 studies could find an actual relationship between the duration of ECMO and outcomes. And I'm not saying that time is not important. I think the clock is certainly ticking. And I think if you can, you should go onto ECMO as soon as possible. But what I noticed in our team and in our unit is that we were so trained as pediatricians that after 30 minutes of CPR, there's no hope anymore. That has been postponed with the possibility of ECPR. So if you have an ECPR program in your hospital, I think it's fair to say that you can you have a little bit more time. And it's not endless. I know there are excessive cases of 220 minutes of CPR with good outcomes, but I think most of us aim to at least have a child on ECMO in 30 to maximum 60 minutes. But you should have a protocol for this in place in your hospital. You should think about this with your team and have a protocol in place and say, when do we alert for ECPR? In which patients? Who do we need? What do we have available? How do we proceed with CPR once the decision has been made to go onto ECMO? What do we do with adrenaline? All these things are discussions can be had, but I think as a team you should have a protocol in place how you approach these patients, and I think there's certainly a room for certain patients with in-hospital cardiac arrest that can be supported with VA ECMO. Like I mentioned, interruption is a bad thing of CPR, so you want to maybe cannulate in the neck possibly so that you don't have to interrupt the chest compressions. In this study, they weren't able to show a difference, but I do think that it makes sense to aim for peripheral cannulation. That's what we attempt to do. It also matters where you are resuscitated, so in the operating room or in the cardiac intensive care unit or in the emergency department makes a huge difference. So and that shows that I think people are more directly available to assist to a circuit, more trained to do this sort of procedure, and that improves your outcome. And to finish off, I think, and this is a main point, you always need to know why your patient ended up on ECMO. So you have to look, if it's a post-op cardiac surgical patient, for residual lesions. You have to do this in several ways. You have to do this with echo, and if that doesn't work, you take your patient to CT or CT angio, or you do a cardiac catheterization, which also allows you to do some intervention if needed. So go and find the problem. With that, I'll skip through to the last question, last slide with my conclusion, if I can find that here, which says that I think in hospital cardiac arrest, with a mean duration of 45 to 60 minutes, can create a survival of about 50%. And I haven't showed you this, but Tim will talk about this, can have some favorable neurological outcomes. And I think that's because we can do a good job in sustaining the circulation, maintaining the circulation in the ROSC period. Whereas if you don't have ECMO, children tend to trundle along and go into multi-organ failure. So that's where I think ECMO has a role. We'll take questions at the end, as the moderators have said. So thank you very much for your attention.
Thank you very much, Peter. That's excellent review of what happens before we get to what the subject is, what the session is about. It gives me great pleasure to introduce Tim Paedratric, who I've known for a number of years.